Hi, Jeremy. Thank you for being early.
Oh, hi, Dr. Masaki. What time does it start?
12:30.
Oh, okay.
So we're gonna,
Yeah.
people are running a little late. We'll give them about a minute.
Okay. Yeah. Sounds good. Thanks.
John, do you have people in the waiting room or should I go ahead and start?
Yeah, I've let them in. I opened it up.
Okay, great. Okay, I'm going to go ahead and start with our introduction. So welcome everybody to the Department of Geriatric Medicine Grand Rounds. Before I introduce our speakers, I have a few announcements to make. This CME activity is jointly provided by the Queen's Medical Center and the UH Jabsom Department of Geriatric Medicine. At this time, please enter the name and credentials of everyone viewing Grand Rounds for CME attendance purposes. As a reminder, you need to complete evaluations for CMEs. You can find the evaluations by following the link that will be put in the chat at the end of this presentation or at any time on our website or on our email advertisement. Your comments are very important to the planning committee and will be used to plan future programs. So today is my favorite Grand Rounds of the year. This is where our fellows present their academic projects every year in June. We're going to have 3 different presentations. The first one is going to be by Dr. Angela Lowe. Angela completed her internal medicine residency at Stony Brook University Medical Center in Long Island. She's finishing her 2nd year of Geri Fellowship in addition to the Jabsom Office of Medical Education Fellowship in Medical Education. And after graduation, she's going to be a teaching attending for the Internal Medicine Residency Primary Care Clinic at Stony Brook University Medical Center. So we'll start out with Angela.
Thanks, Dr. Masaki. Okay, can you guys see the screen?
Perfect.
Okay, thank you. Thank you for having me. My name is Angela Lowe, and I will be presenting my curriculum project from the Fellowship for the Office of Medical Education. And it's about the Geriatrics 5Ms curriculum for internal medicine residents. So next fall, I'll be a teaching attending at the Internal Medicine Resident Primary Care Clinic at Stony Brook. I did attend there as a student, a medical student, as well as an internal medicine resident. But unfortunately, as a resident, I did not have as much dedicated didactics to geriatrics as I would have liked. So just a little bit about the population. So I will be in Suffolk County, Long Island in New York. And in Long Island, compared to a decade ago, it has about 110,000 more older adults. In Suffolk County, there's also been an increase of about 33% in adults 65 and older. And in total, they have about 250,000 adults 65 and older. There's also been a 56% increase in adults 85 and older, and unfortunately a 33% increase in older adults in poverty. In Suffolk County alone, there are 41 nursing homes, with one of the largest having 460 beds. And in comparison to the state of Hawaii, Hawaii has 45 nursing homes. So a little similar in the numbers. In addition, Stony Brook actually has a Center for Healthy Aging, which unites leading researchers and clinicians who are focused on enhancing the health and wellness of people as they age. And the goal is to promote healthy aging and to extend both physical and mental well-being through innovative research solutions. So I'm hoping to also extend this emphasis on healthy aging to our medical education for our medical residents. So I'm hoping for the learners from my curriculum to have improvement in perception and confidence in care for geriatric patients. As part of the curriculum development, we also have to do a needs assessment. So I did an informal interview of prior residents who were called no formal didactic curriculum. And I also did meet with the current internal medicine primary care clinic director and a geriatrics clinical educator from Stony Brook. They did recall having a prior dedicated lecture on transitions of care, a GERI topic, but unfortunately that was discontinued during the COVID-19 pandemic and it had not been reintroduced into the internal medicine curriculum. And that was the only geriatrics didactic that the medicine residents had. I did have the opportunity though to go to AGS this past May, and there was a session dedicated on teaching geriatrics to residents in IM and FM. And in particular, they also talked about the updated family medicine and internal medicine resident competencies in geriatrics. So I was able to include these competencies as different objectives for my curriculum. So for my curriculum goals, I included that residents will gain better understanding of the geriatric 5 M's. Residents will build confidence in approaching common geriatric syndromes. Residents will have increased appreciation for the specialty of geriatric medicine. And residents will build confidence in caring for geriatric patients in whichever specialty they choose to practice in. So a little bit more about the IM residency. They have a 4+1 schedule. So that means they spend 4 weeks inpatient and then 1 week outpatient, and that's their continuity clinic. So every Wednesday during their outpatient week, they have an academic Wednesday. So this is comprising of different lectures, didactics, and workshops. So for my curriculum, this would require 3 different workshops to address the 5 M's. One workshop would be given to the residents each year during an academic Wednesday. And then the workshops would rotate on a 3-year cycle. So by the time my resident graduates, they would have completed all 3 workshops. So the first workshop I had was all about mind. So here are the listed objectives. The first topic would be about cognitive concerns. So I'd want the learner to be able to normal aging from other conditions like dementia, delirium, mood disorders, substance use disorder, and be able to address the interaction among them. Another major topic is capacity. So we'd like to have the learner be able to determine if an older adult has capacity for making a medical decision, and if not, be able to identify and engage the legal surrogate decision maker. We also want them to be able to recognize delirium, diagnose, initiate workup, and treat underlying causes, as well as mitigate risk factors for hospitalized older adults. And then agitation management is also a huge topic. So we'd like the learner to be able to identify and treat reversible causes of agitation, work with an interprofessional team to come up with strategies that minimize the use of pharmacological and physical restraints. The second workshop would be about mobility. So this is the first part of the second workshop. And here we would focus on functional assessments. So the learner should be able to perform this assessment, including ADLs and IADLs. And then they should be able to work with interprofessional team members to optimize the older adult's functional status, especially during hospitalization, transitions of care, and post-discharge follow-up. The learner should also be able to perform and interpret a gait and balance assessment for mobility assessment using validated screening tools, and they should screen for fall risk factors, including the improper use of assistive devices. In addition, the learner should be able to identify fall and fracture risks and help with management plans to reduce these risks. So they would be able to collaborate with an interprofessional team to come up with a plan that reduces risks, including physical and occupational therapy, assistive devices, med review, environmental modification, and optimization of vision and bone health. The second part of the second workshop would be about medications. So one topic would be about prescribing. So medical residents should be able to review the medication list, prescribe medications that are duplicates or potentially inappropriate, high risk, or lack a current indication. They should also be able to identify if there are barriers to adherence and discuss alternatives and ways to decrease adverse effects of different meds. They should also learn more about geriatric pharmacology. So ideally, the learner should be able to justify their drug selection and dosing based on age-related physiologic changes, and the older adults' comorbidities, functional status, and other meds that can increase the risk of side effects. And then lastly, there's also prescribing cascades. So the resident should be able to determine whether a new symptom in an older adult is maybe due to a medication adverse effect, drug-drug interaction, or drug-disease interaction, and modify that treatment as needed to avoid this prescribing cascade. The third workshop would be about multi-complexity and what matters most. So under multi-complexity, we would discuss health equity, transitions of care, so coordinating safe and effective care transitions while taking into consideration the older adult's needs, preferences, goals, and resources. We'd also look into the hazards of hospitalizations. So not only should they be able to identify hazards, but also demonstrate a proactive approach to prevent these hazards. And then for hospitalized older adults, the learner should also be able to assess and document presence of delirium, pressure injuries, and bowel and bladder activity. And then the learner should also identify atypical presentations or geriatric syndromes when they're coming up with a differential diagnosis for an older adult. Furthermore, residents should be able to identify any sensory impairments and develop a treatment plan that optimizes their communication, cognition, and function in those with sensory impairments. They should be able to assess an older adult's nutritional status and develop initial management plans for those in need. When evaluating an older adult, they should be able to take into account the patient's aging physiology when interpreting physical exam findings, diagnostic test results, and coming up with treatment plans. Residents should also be able to define frailty and incorporate frailty status into their evaluation and management plans. And they should also be able to identify older people who are in potentially unsafe situations, perhaps due to living environment, caregiver stress, elder mistreatment, self-neglect, or at-risk driving. And then they should also be able to work with an interprofessional team to balance the patient's autonomy and safety. And lastly, we also talk about what matters most. So they should be able to elicit patient priorities and include them in management plans, lead advanced care planning discussions, identify healthcare proxies. They should also be able to utilize and apply tools for prognostication and thus individualized treatment plans based on patients' overall prognosis, function, cognition, and patient priorities. So my workshops would be ideally 2 to 3 hours each. There would be a pre-workshop questionnaire to assess baseline knowledge of the residents of the topics to be discussed. The workshops would consist of a mix of presentations, small group work for case discussion and practice with different geriatrics tools like using a SLUMS, gait evaluation. And then the last 15 minutes of the workshop would be for post-workshop questionnaire to assess their knowledge and evaluation of that workshop. And so for the evaluation, we would use the pre and post workshop questionnaires to assess perception on geriatrics and confidence in geriatrics care, as well as assess the value for curriculum. We check for post-workshop understanding of the topic. And then for overall curriculum evaluation, we'd also discuss with the program director and head of the geriatrics resident rotation. I'd also seek feedback from geriatrics attendings to check for notable changes in resident performance and attitudes. You could also use this for scholarly work. We can look at the pre and post workshop results to assess for any changes in perception of geriatrics or changes in level of confidence in caring for geriatrics patients. So for the next steps, I'll be continuing to edit workshop materials. I will collaborate with the geriatrics faculty at Stony Brook and present the curriculum to the internal medicine program director. And I hope to aim to roll out the curriculum for the academic year of 2024 to 2025, because unfortunately the upcoming academic year is fully booked. But thank you so much for having me.
Thank you so much, Angela, for an excellent presentation and a wonderful project. And we wish you all the best as you spread geriatrics in New York. And remember to keep sending us fellows our way too.
Thanks, Dr. Masaki. Will do.
We're going to save all the questions until the end. So the next presentation is going to be from our other second-year fellow, Dr. Susan Christensen. Dr. Christensen has a background in family medicine. She was actually in primary care practice for nearly 20 years when she realized how complex it was for her older patients and decided to come back to do her geriatric fellowship. After graduation, she will be joining the Queen's University Medical Group in the post-acute long-term care service. Susan is unfortunately on a trip, but she has a video. So please go ahead and play her video for us, John. Thank you.
Good afternoon, everyone. I'm so sorry that I can't be there with you live this afternoon. Before I get started, I need to state that I have no conflicts of interest. Today, I'm going to share with you the process behind adapting the Geriatrics Fellowship, Law and Ethics curriculum to an interdisciplinary audience. The impetus for undertaking this project is my participation in the Office of Medical Education Teaching Fellowship taught by Dr. Richard Kasuya. This experience has had a profound impact on my professional trajectory, and I'm pleased that I have the opportunity to share it with you today. As with any project, it helps to lay your groundwork. The search for a curriculum project began with a needs assessment. One of the positive effects of the pandemic has been the ability to take advantage of online teaching formats to reach more students. Within the geriatrics department, there had been increasing requests from other disciplines to work geriatric education into their curriculums. Our faculty felt the department could revamp some of the fellow didactic material to be taught in an interdisciplinary format. The faculty had also already identified the law and ethics curriculum as one of the topics that was of broad interest to multiple disciplines. With a few months of lead time, I was offered the opportunity to develop it. Next, I checked with my peers. They agreed that the law and ethics curriculum, as it was taught in previous years, could be streamlined. Each of the speakers covered very important material, but because they were not coordinating with each other, there was often redundant and sometimes even conflicting information. Finally, I spoke with the team of interdisciplinary educators I hoped to include in my seminars. There was general agreement that teaching law and ethics from a single lens is limiting, and they could see a lot of value in a group teaching approach to this complicated subject matter. With the overwhelmingly positive response to the concept of an interdisciplinary course on law and ethics, I undertook a brief literature review to see what was being done already. There are many current resources supporting the real-world applicability and general student satisfaction with this approach. The articles listed here are purely for example. They are not important specifically to the talk, so don't worry about the small print there. After that background research was completed, I was able to answer the question of why making the change to the curriculum would be valuable and what the specific goals would be. So I created this rationale statement, also called the elevator pitch. Supporting older adults as they age requires the collaboration of an interdisciplinary team, particularly when faced with challenging legal and ethical issues. By creating a multidisciplinary medical law and ethics curriculum, we are educating new healthcare professionals on how they can work together to ensure the health, safety, and well-being of our older adult population. I would like to draw your attention to the goals I set for this course. In particular, I don't want to simply impart knowledge to them, to the students. I want to shape their attitudes towards working in team-based models of healthcare. I want each person to know their value and be able to build upon what others bring to the team. I also want to improve their satisfaction with the educational experience. These are the 5 key objectives of the course. First, I want each student to be able to describe the value, role, and responsibilities of each member in an interdisciplinary team. As we go into real-world scenarios, we don't have a set team in every setting that we work in. Sometimes it's the doctor and the physical therapist. Sometimes it's the nurse and the pharmacist. We can come together in all different kinds of teams to work for the patient. Knowing who can do what and who's going to do what, and stating that within your team is a very important skill. Next, I want the students to be able to identify and prioritize ethical principles at play in common geriatric dilemmas. So dilemmas are some of the most challenging situations we find ourselves in. This is where conflict between values, what's important to us as the caregivers and providers, and what's important to the patient may not always align. And we need to be able to identify what is happening when we feel uncomfortable so that we can come to a resolution. Thirdly, students will be able to state the legal definition of capacity and how it impacts healthcare decision-making. Is a patient able to consent? Do they understand what is happening? And if they can't speak for themselves, who can speak for them? Next, students will understand the physical and cognitive changes of aging and the effects on independent living. How do we keep our kupuna safe in their homes? And when do we step in when it becomes apparent that they need help? Lastly, I expect the students to be able to locate online and community resources for supporting elders and their family members. Knowing where to go to get assistance is so critical to being able to do the work that we do. We are not working in isolation. We always have people we can call upon. Now for the fun part. How did I decide to do this? We started with the participants, who would be included in the interdisciplinary makeup of the student body. It's going to have to change from year to year depending on the program needs of those that we invite. But this year, the interprofessional teams included were the geriatrics fellows, law, DNP or Doctor of Nursing practice, social work, and public health students. The format consisted of 3 separate 2-hour seminars featuring a panel of experts, each of whom had the opportunity to provide a mini lecture, and then were informants on case discussions. Prior to each session, the students were asked to complete a 15-minute educational module. The purpose of the modules was threefold. They served as pre-knowledge assessment, They reduced the amount of time spent on lecturing so that we can have the mini lectures rather than full lectures on each of the topics. And it allowed for more interactive discussions because the students came in with some baseline knowledge. Next, we do. In February, the curriculum was ready to take live. Each of the 2-hour seminars had defined topics, and field experts were identified and invited to join the panel. For the first seminar, our panelists consisted of a geriatrician, a psychiatrist, a lawyer, a social worker, a certified guardian, and a caseworker from Adult Protective Services. The topics flowed nicely together, from team-based care to capacity and consent to healthcare ethics, and lastly, abuse and neglect. The second seminar, we were able to have a palliative care physician, a lawyer, a public health expert in the field of death and dying, and a social worker who helped us discuss advanced directives versus post, identifying healthcare agents, and end-of-life controversies. For the final seminar, our panelists consisted of a social worker, a certified guardian, a lawyer, and a program coordinator from Catholic Charities Hawaii to discuss elders living alone and driving cessation. So how are we going to evaluate our program now that it's in full motion? First, we have the pre-work modules with questions built in to assess baseline knowledge and demographics, including discipline. At the end of the entire series, there was a single summary evaluation that attempted to meet all of these aims that you see here: collecting post knowledge, attitudes, satisfaction with the training, quality of training, and skills and comfort levels. Yeah, we'll talk about that in a few minutes. All right, now that our course is complete, it's time for us to study what has happened. So what went well? Good afternoon. I'm sorry I cannot be with you live today. Before I get started, I need to state that I have no conflicts of interest to report. Participants felt that today I'm going to share with you the process behind adapting by hearing the geriatric fellowship, discipline, and ethics curriculum to an interdisciplinary audience. By hearing each of the panelists
John,
their different is my participation in the Office of Medical Project is my Good afternoon.
John, there seems to be a problem with the video. Yeah.
I just skipped that portion. I think I got the right part. Hold on.
Thank you.
Lessons learned. What could have gone better? First of all, the seminars were designed to build on one another, and they were meant to be attended as a series, not individually. However, this intent was not clearly communicated to all of the participating departments. I was able to partially address the missed content for students who were coming to the second or third seminars by including some review slides for the benefit of the new attendees. This actually worked out pretty well because it updated the new panelists as well as to what had been covered already. Secondly, I found it very difficult to overcome a passive learning state. When I began my process, I had in mind a much smaller number of participants, maybe 15 to 20. And if I could see all of them on Zoom, I could use more of a Socratic method and fire off questions to the students. Fortunately, unfortunately, we had upwards of 30 students, as well as several faculty observers, which rendered it impossible to engage all of them for the entire 2 hours. This meant that the case discussions were more of a dialogue between the panelists. The students did take advantage of the chat box to pose great questions, so I do know that some of them were listening. The greatest lesson learned I attribute to being a rookie in academia, and that was data collection. Even with experienced survey writers in my back pocket, the design of my evaluation did not lend itself well to translating into meaningful data. The first mistake was thinking I could have one survey that covered all 3 seminars. Well, let's just say garnering participation from students who did not attend the 3rd seminar was very challenging, i.e., it didn't happen. The second difficulty was the structure of my questions. I'm sure most of you know Dr. Masaki and her enthusiasm for cleaning up data. Well, when she met with me so we could work through it, I could actually see Dr. Masaki deflate as she began to digest what I had created. It was kind of like biting into the delicious meal that your child had created and then realizing that they had tripled the salt. Okay, so now we act. What is up next for this project? I am thrilled to report that I will have a second go at this curriculum in 2024. While there are small tweaks that I can make in the modules, order the topics differently, and invite different panelists, there's really one critical aspect that needs my attention, and that is the evaluation process. As I mentioned, the survey data collected this year is basically unusable, but that is the beauty of the Plan, Do, Study, Act cycle. We get to do it again. Next year, I won't be creating the surveys on my own. I can take advantage of these experts that I have all around me. Though I secretly do wonder if I can use my efforts from this year in a future educational context to demonstrate what happens when you don't know what you are doing. I also recognize that it is essential to have the students do the evaluations immediately after each session. I wanted to know how they felt about how the panelists gelled and the flow of the content, but I can't get that kind of data and have it be relevant if there's a 3-week delay from when the students saw the presentation to when they evaluate it. And then lastly, in recognizing that I have little control over students in other departments, it was impossible to track them down and make them complete a survey after the fact. At least we could see that the geriatrics fellows had all completed the surveys. Thank you, team. For next year, we are already devising a plan to issue a certificate of participation to the students' program coordinators once their evaluations are received. We can make their programs wield the stick. So there are a few opportunities, and I'm sure I'll come up with some more as we prepare for next year's cycle. This curriculum has a lot of potential for reaching a wide variety of audiences. I've already had the opportunity to present smaller pieces of it in both community and professional settings, and the information continues to be well received. The geriatrics department aims to share this curriculum with other programs so that they can start taking advantage of interdisciplinary learning. We are fortunate here in Hawaii that all of these training programs are in close proximity, and we do get to work closely with each other. The Zoom format will allow geographically distant training programs in different disciplines to work together. Thank you very much for your attention today. I would be happy to take your questions over email if the geriatric faculty who are present today can't answer them for you. Aloha.
Thank you, Susan, for an excellent presentation and a very ambitious and well-done project. No, there are problems with the data collection, but it's not as bad as she says, and I'm sure we'll be able to make something of it, okay? So our last project is going to be presented by all of our first-year fellows who did a group project for quality improvement. Before I show the slides, I'm going to do a quick introduction of all of our first-year fellows. First, we have Monica Orsine. Monica is originally from Hawaii, went away for family medicine residency in New York, then returned here for Geri Fellowship. And she will be moving to Northern California. She's going to be practicing geriatrics at Kaiser there. Next is Geri Sylvester. Geri is also originally from Hawaii, moved around a lot with a military spouse, and then came back here to Hawaii for her Geri Fellowship. And when she graduates, she will first be doing a locums position for a few months at Kaiser with their Department of Geriatrics, and then joining the Queen's University Medical Group to do inpatient geriatric consults. Next is Gul Mavish. Gul grew up in Pakistan. She first did her residency in Long Island in internal medicine. And after she graduates, she's going to be moving to Florida. She's going to be joining the Baptist group, which is affiliated with the University of Miami as a geriatrician and primary care physician. Next is Kelly Kurosaki. Kelly grew up on Kauai, did her internal, she's a JABSOM grad, did her internal medicine residency in family medicine residency in Washington State, and then did her geriatric fellowship. And she's going to be staying for a second year of fellowship. And last but not least is Muhammad Ali. Muhammad completed an internal medicine residency right here at University of Hawaii. After he finishes geriatric medicine fellowship, he's going to be joining the Queen's Hospitalist Group. So I'm going to be sharing my slides and moving the slides for the fellows. So let me do that right now. Okay, fellows, it's all yours.
Thank you, Dr. Masaki, for the introduction. The title of our quality improvement project is Improving Communication Skills Amongst Clinicians Through Formal Evidence-Based Training. We would like to first acknowledge the authors listed on the slide, as well as faculty and the Department of Geriatric Medicine, JABSOM, the University of Hawaii, and the Queen's University Medical Group. Thank you for the development of this quality improvement project. Next slide, please. I would like to first provide background on what led to the development of this project. Communication skills are crucial for clinicians to provide patient-centered care. Communicating to patients and families about serious illness is challenging. These types of conversations require skills that many clinicians do not have formal training in. In fact, only 14% of physicians report advanced care planning discussions with patients, and over 60% report that they have never received formal training. VitalTalk is a program that provides evidence-based training using simulated patients to train clinicians how to communicate effectively with seriously ill patients and their families. Next slide. So the objective of this quality improvement project, we assessed whether training used simulated patients with VitalTalk program improved geriatrician skills and confidence in communicating with patients and families about serious illness. So the next section of this project, Dr. Kurosaki will talk about the methods. Thank you.
Okay, so all the geriatricians at the Queen's University Medical Group and University of Hawaii participated in this training. So we had 22 people involved. They attended a 4-hour VitalTalk training session on Zoom, or they participated in the VitalTalk web-based training. and the trainings were completed from July to September 2022. Next slide, please. And then after completion of the training, they completed a retrospective pre-post survey related to their skills and comfort level with different communication skills. The data was analyzed using descriptive statistics and paired t-tests, comparing the differences between the pre and post scores. And now Dr. Ali will be presenting the demographic results.
Thank you, Kelly. So as you can see, our geriatricians form a diverse group. We are mostly female, so 77% of the group was female. Of the practice settings, there was diverse areas of practice, split kind of somewhat evenly between inpatient house calls, PA, LTC, and clinic, although post-acute and long-term care was the largest group. Ethnicity, again, it's kind of split between mostly white, Chinese, and Japanese Okinawan populations, with a small amount of other Asian and mixed groups. And in terms of religion, half the population identified no religious leanings, a quarter were Christian, and a quarter were other.
Hi, I'm going to present the results for the rating quality of training. So first of all participants completed the evaluations, and evaluation scores are rated on a 5-point Likert scale. In this first chart, you can see the scale range from 1 to 5, 1 being poor, 5 being excellent. The baseline mean scores on quality of training were high, ranging from 4.5 to 4.88 in this chart. Next slide, please. In this second chart, the scale range from 1 meaning strongly disagree to 5 strongly agree. And the baseline mean scores here ranged from 4.45 to 4.95. Again, generally high ratings. And you can kind of just see the general idea of like the questions that were asked in these evaluations, like would you recommend this to others? And should all healthcare providers receive this training? Dr. Mavish will now present the results of pre and post training ratings.
Thank you, Jerry. Next slide. Yes. So this is retrospective pre and post training ratings regarding the skills and comfort in the discussions regarding various topics. So skills in discussing the clinical status improved from 3.6 to 4.1. Comfort in discussing clinical status improved from 3.5 to 4.14. Skills in discussing goals of care improved from 3.7 to 4.18. Comfort in discussing goals of care improved from 3.7 to 4.18. Skills in discussing advanced care planning improved from 3.8 to 4.2. And comfort in discussing the advanced care planning improved from 3.8 to 4.1. And all of these have significant p-value, as you can see. Next slide. So this is the retrospective pre and post training ratings regarding self-assessment of communication skills. So they use the same Likert scale from 1 to 5, 1 being poor and 5 being excellent. So regarding assessment, what patient already knows, it improved from 3.6 to 4.09. Giving a headline, delivering news also improved from 3.05 to 4.09. In the same way, responding to patient's emotion also improved from 3.36 to 4.09. Aligning with patient's hope and then share their concerns also improved from 3.41 to 4.18. Managing uncertainty and conflict also improved from 3.14 to 3.7. Promoting prognostic awareness also improved from 3.45 to 3.9. Eliciting patients' goals and values also improved from 3.6 to 4.05. And recommendations and treatment regarding the goals of care values and how to support the goals and values of the family and the patient also improved from 3.6 to 3.9. and all these have significant p-values. Next, Mohammed will present communication skills. Thank you.
Thanks, Atmavish. So we did further follow-up at 1 and 3 months to assess retention of skills. And of the group, about 18 out of 22 had reported that they continued to use the skills. And we saw initially, if you look at the graphs, this compares people who use the skills in discussing clinical status, discussing goals of care, and discussing advanced care planning. And this is the number of times or the number of patients that they use these skills with. And you can see at 1 month training, the numbers are somewhere around 3.82 to 4.45, so about 4 patients on average. We actually saw a very large increase from 1 month to 3 months, where it seemed that perhaps once people started using the skills and becoming more comfortable with them, they started using them more. So at 3 months, we see that on average, people were using the patients somewhere around 9.91 to 11.09, so around 10 to 11 times since using the training. So overall, we saw a good retention over a prolonged period of time after the training was completed. And Dr. Orsine will conclude the talk for us.
Thank you, Dr. Ali. So for conclusions, formal evidence-based training using VitalTalks was rated very highly. At 1 month and 3 month follow-ups, 18 out of 22 geriatricians, about around 82% had used skills gained from the training and continue to rate the training highly. Next slide, please. So for future directions, all providers should receive formal communication training. Although it is time and resource intensive, providers need to be reminded to use these learned skills to reinforce learning and continue to improve confidence over time. In fact, there's a VitalTalk app is available. Next slide, please. Thank you. Any questions?
We'll open it now to our audience to ask questions of any of our speakers, any of the talks that you heard. Any questions or comments for our fellows? Jake has a question for Angela in the chat. Angela, where, if at all, would you touch on HBPC in your geriatrics program? Great question.
That's a good question. I think, well, ideally it would be dispersed. I'm thinking about the different 5 M's, but maybe a multi-complexity when we talk about those discussions where maybe the older adult will be requiring more help at home because of their functionality. Could also be in terms of mobility. We can touch upon HBPC there. Actually, I'll be doing home visits too, in addition to precepting. So I'll be taking on learners and we'll be interspersing there. But in the curriculum, I'm seeing maybe more mobility and maybe multi-complexity.
Thanks, Angela.
Thank you.
Any other comments or questions from anyone? While we wait for questions, I just want to remind everyone again, for CME, you do need to go into the evaluations and complete the evaluations. John, could you put the evaluation link into the chat box, please, for people? And also you can get the evaluation link off the email advertisement or of your registration. Oh, John just put it on. Thank you, John. Okay, Naomi says, I'm impressed by the value of the projects and how continued utilization will improve the skills of learners on all levels. Yeah, thank you, Naomi. And Warren said, very nice presentations. So fellows, all your hard work has been very much appreciated by all of us. We congratulate all of those of you who are graduating. Kelly, we are thrilled you're staying with us for another year. And faculty, we hope to see you all again next year as next year's group presents their various research, education, or quality improvement projects. So congratulations to the fellows. Okay, thank you everyone for your attention. Bye-bye.